Emily just dislocated her shoulder, which as we saw can be quite painful. This injury is relatively common in young, active adults, although it is most common in young men. Emily fell with her arm outstretched in front of her. The force of the impact caused the head of the humerus to slide out of the glenoid cavity. A 2012 study by Tanaka and colleagues found that dislocations typically occur at 90 degrees of abduction and a range between 65 degrees of external rotation to 8 degrees of internal rotation. This is likely the range that poor Emily had her arm in when it hit the ground.
No way, I'm not touching that. I'm gonna hear about it for the next 50 years. It hurts. Okay, let's just try and get you up and then we'll walk to Fowler. We're not that far away. No. Come on. Oh. Okay, let me just put this under your arm. Oh, just.
There are many techniques available to reduce a shoulder dislocation. It should be noted that it is best to get a trained professional to reduce a dislocated shoulder. There can be complications like a fracture that need to be accommodated first. However, in a survival situation where you are days away from help, a reduction may be necessary to prevent nerve and vascular damage, and to reduce the pain so that the injured person can get back to safety.
Two of the most popular methods of reduction are the Milch and Stimson techniques. The patient may be supine or prone with the shoulder close to the edge of the stretcher. The affected arm is placed in full abduction overhead, where the patient is instructed to raise the arm laterally and behind the head. The trained individual may assist abduction gently. With the patient's arm in full abduction, the trained individual gently applies longitudinal traction and external rotation with one arm. If reduction is not completed, the trained individual uses the thumb or fingers to push the humeral head up into the glenoid fossa with gradual abduction of the extended arm. For the Stimson technique, the patient is placed in the prone position on an elevated surface. The injured shoulder is off the bed, hanging downward in 90 degrees of forward flexion, without the arm touching the floor. 5 to 10 pounds of weight is securely fastened to the wrist of the affected arm to provide continuous traction. The patient is instructed to maintain this position for at least 15 to 20 minutes or until reduction is accomplished. To facilitate reduction, the physician may apply gentle external rotation of the extended arm, flexion of the elbow 90 degrees, or scapular manipulation.
Okay, let's go to the trainer's room, see if there's any trainers in there.
Alright, so we're going to use the Milch technique to put it back in.
Okay.
Let me know if you need me to stop.
Oh, that feels so much better.
Alright, the next step is to get you immobilized. Okay. Immobilization of the shoulder after a dislocation gives comfort to the patient and allows the healing process to begin. In a survival situation, a sling should be fastened that reduces arm movement, and the easiest way of doing that is to have the arm held to the body. However, Lodi and colleagues have found that immobilizing the shoulder in external rotation, rather than internal rotation, better protects against future dislocations and subluxations. It's most beneficial if done in the first 24 hours after the dislocation, so it's important that Emily get back to the clinic to be properly immobilized. Okay, so we've immobilized you in external rotation for the best possible recovery. Just need to check the sensation there. Can you feel that?
Yep.
Your circulation there, which is good. So you're going to need to wear this for 24 hours a day, except for showering, for the next 3 weeks. Sound good?
Yep.
So there's two options for what Emily can do moving forward. She can either continue with this conservative treatment of immobilization and then start rehab, or she has the option of an invasive surgical procedure which will repair any of the torn tissues. The surgery has been shown to be more effective than the conservative treatment in avoiding future dislocations, but leads to a longer recovery time and has the risk of infection or nerve damage. However, Emily is in the demographic of young, active adults who seem to benefit most from the surgery. If she were older and inactive, I may not recommend it. So what do you think?
Well, I play rugby and I'd like to continue to play without worrying about dislocating it again.
In that case, I'll refer you to a surgeon.
Thanks.